This is the audio lecture for Chapter 14, Pain Management. Pain is an unpleasant, complex, highly individualized phenomenon with sensory and emotional components. Pregnant women commonly worry about the pain they will experience during labor and birth and about how they will react to and deal with that pain. A variety of non-pharmacologic and pharmacologic methods can help the woman or the couple cope with the pain of labor. The methods selected depend on the situation, the availability, and the preferences of the woman and her healthcare provider. This lecture will discuss sources of intrapartum pain and factors that affect women's response to pain. It will also describe non-pharmacologic and pharmacologic methods commonly used for pain relief. Pain during labor and birth. The pain and discomfort of labor have two origins, visceral and somatic. During the first stage of labor, uterine contractions cause cervical dilation and effacement. Uterine ischemia results from compression of the arteries supplying the myometrium during uterine contraction. The pain from distension of the lower uterine segment, stretching of cervical tissue as it effaces and dilates, pressure and traction on adjacent structures and nerves, and uterine ischemia during the first stage of labor is visceral pain. It is located over the lower portion of the abdomen. Referred pain occurs when pain that originates in the uterus radiates to the abdominal wall, lumbosacral area of the back, iliac crest, gluteal areas, thighs, and the lower back. During the second stage of labor, the woman has somatic pain, which is often described as intense, sharp, burning, and well localized. This pain results from distension and traction on the peritoneum and uterocervical supports during contractions, pressure against the bladder and rectum, stretching and distension of perineal tissue and the pelvic floor to allow passage of the fetus, and also lacerations of soft tissue such as in the cervix, vagina, and perineum. Again, the two origins of pain. The first stage of labor, the pain is visceral pain. During the second stage of labor, the pain is somatic pain. Pain experienced during the third stage of labor and the after pains of the early postpartum period are uterine, similar to the pain experienced early in the first stage of labor. This is figure 14-1 in your textbook titled Pain During Labor. If you look at the picture, letter A shows the distribution of labor pain during the first stage. B, distribution of labor pain during transition in the early phases of the second stage. C, distribution of pain during the late second stage and actual birth. The gray areas indicate mild discomfort. Light pink areas indicate moderate discomfort. Dark red areas indicate intense discomfort. Perception of pain. Although the pain threshold is remarkably similar in everyone regardless of gender, social, ethnic, or cultural differences, these differences play a definite role in the person's perception of and behavioral responses to pain. The effects of factors such as culture, counterstimuli, and distraction in coping with pain are not fully understood. The meaning of pain and the verbal and nonverbal expressions given to pain are apparently learned from interactions within the primary social group. Cultural influences may impose certain behavioral expectations regarding acceptable and unacceptable behavior when experiencing pain. Pain tolerance refers to the level of pain a laboring woman is willing to endure. When this level is exceeded, she will seek measures to relieve the pain. Factors that influence a woman's pain tolerance level and her request for pharmacologic pain relief measures include her desire for a natural vaginal birth, her preparation for childbirth, the nature of her support during labor, and her willingness and ability to participate in non-pharmacologic measures for comfort. Expression of pain. Pain results in physiologic effects and sensory and emotional responses. During childbirth, pain gives rise to identifiable physiologic effects. Sympathetic nervous system activity is stimulated in response to intensifying pain, resulting in increased catecholamine levels. Blood pressure and heart rate increase. Maternal respiratory patterns change in response to an increase in oxygen consumption. Hyperventilation, sometimes accompanied by respiratory alkalosis, can occur as pain intensifies, and more rapid, shallow breathing techniques are used during contractions. Pallor and diaphoresis may be seen. Gastric acidity increases, and nausea and vomiting are common in the active and transition phase of the first stage of labor. Placental perfusion may decrease, and uterine activity may diminish, potentially prolonging labor and affecting fetal well-being. Certain emotional expressions of pain are often seen. Such changes include increase in anxiety with lessened perceptual feel, writhing, crying, groaning, gesturing, and excessive muscular excitability throughout the body. Factors influencing pain response. Pain during childbirth is unique to each woman. How she perceives or interprets that pain is influenced by a variety of physiologic, psychologic, emotional, social, cultural, and environmental factors. Physiologic factors. A variety of physiologic factors can affect the intensity of childbirth pain. Physical factors that affect pain intensity include fatigue, the interval and duration of contractions, fetal size and position, rapidity of fetal descent, and maternal position. Culture. Nurses should recognize that although a woman's behavior in response to pain may vary according to her cultural background, it may not accurately reflect the intensity of the pain she is experiencing. The nurse must assess the woman for the physiologic effects of pain and listen to the words she uses to describe the sensory and affective qualities of her pain. Anxiety. Anxiety and fear heighten, muscle tension increases, the effectiveness of uterine contractions decreases, the experience of discomfort increases, and a cycle of increased fear and anxiety begins. Ultimately, this cycle will slow the progress of labor. Previous experience. Previous experience with pain in childbirth may affect a woman's description of her pain and her ability to cope with the pain. Childbirth for a healthy young woman may be her first experience with significant pain, and as a result, she may not have developed effective pain coping strategies. She may describe the intensity of even early labor pain as pain as bad as it can be. The nature of previous childbirth experiences also may affect a woman's response to pain. For women who have had a difficult and painful previous birth experience, anxiety and fear from this past experience may lead to increased pain perception. That is why I tell each woman to view each pregnancy differently. Just because she had a bad experience in one pregnancy does not mean she's going to have a bad experience in future pregnancies. Gate control theory of pain. The gate control theory of pain helps explain the way hypnosis and the pain relief techniques taught in childbirth preparation classes work to relieve the pain of labor. According to this theory, pain sensations travel along sensory nerve pathways to the brain, but only a limited number of sensations or messages can travel through these nerve pathways at one time. Using distraction techniques such as massage or stroke, music, focal points, and imagery reduces or completely blocks the capacity of nerve pathways to transmit pain. These distractions are thought to work by closing down a hypothetic gate in the spinal cord, thus preventing pain signals from reaching the brain. The perception of pain is thereby diminished. Comfort and support. Although the predominant medical approach to labor is that it is painful and the pain must be removed, an alternative view is that labor is a natural process and women can experience comfort and transcend the discomfort or pain to reach the joyful outcome of birth. Current evidence also indicates that a woman's satisfaction with her labor and birth experience is determined by how well her personal expectations of childbirth were met and the quality of support and interaction she received from her caregivers. The environment. The quality of the environment can influence pain perception and the laboring woman's ability to cope with her pain. Environment includes the individual's present and the physical space in which the labor occurs. Women usually prefer to be cared for by familiar caregivers in a comfortable home-like setting. The environment should be safe and private, allowing a woman to feel to be herself as she tries out different comfort measures. Non-pharmacologic pain management. Non-pharmacologic measures are often simple and safe, have few if any major adverse reactions, are relatively inexpensive, and can be used throughout labor. In addition, they provide the woman with a sense of control over her childbirth as she makes choices about the measures that are best for her. During the prenatal period, she should explore a variety of non-pharmacologic measures. Techniques she usually finds helpful in relieving stress and enhancing relaxation may be very effective as components of a plan for managing labor pain. The woman should be encouraged to communicate to her healthcare providers her preferences for relaxation and pain relief measures and to actively participate in their implementation. Often, non-pharmacologic methods are used in combination with pharmacologic methods, particularly as labor progresses. Childbirth preparation. The childbirth education movement began in the 1950s. Today, most healthcare providers recommend or offer childbirth preparation classes for expectant parents. Historically, popular childbirth methods taught in the United States were the Dick Reed method, the Lamaze method, and the Bradley method. And you can read more about the current offerings in your textbook, Hypnobirthing and Birthing from Within. Alternative therapies. Relaxation or reduction of body tension is a technique suggested by virtually all childbirth education organizations. Imagery and visualization are useful techniques in preparation for birth and are often used in combination with relaxation. Breathing techniques. Different approaches to childbirth preparation stress varying breathing techniques to provide distraction, thereby reducing the perception of pain and helping the woman maintain control throughout contractions. Effleurage and counterpressure. Effleurage, also known as light massage, and counterpressure have brought relief to many women during the first stage of labor. The gate control theory may supply the reason for the effectiveness of these measures. Effleurage is light stroking, usually of the abdomen, in rhythm with breathing during contractions. It is used to distract the woman from contraction pain. Counterpressure is steady pressure applied by a support person to the sacral area with a firm object, usually a tennis ball, or the person may use the fist or heel of the hand. Touch and massage. Touch and massage have been an integral part of the traditional care process for women in labor. A variety of massage techniques have been shown to be safe and effective during labor. Application of heat and cold. Warm blankets, warm compresses, heated rice bags, a warm bath or shower, or a moist heating pad can enhance relaxation and reduce pain during labor. Heat relieves muscle ischemia and increases blood flow to the area of discomfort. Cold applications such as cold cloths, frozen gel packs, or ice packs applied to the back, the chest, and or the face during labor may be effective in increasing comfort when the woman feels warm. They also may be applied to areas of musculoskeletal pain. Cooling relieves pain by reducing the muscle temperature and relieving muscle spasms. Acupressure and acupuncture. Acupressure and acupuncture can be used in pregnancy, in labor, and postpartum to relieve pain and discomforts. There are other alternative therapies that can be used with the laboring woman. These include transcutaneous electrical nerve stimulation, water therapy, intradermal water block, aromatherapy, hypnosis, biofeedback, and music. Please read over these therapies in your textbook. This is figure 14-5 in your textbook. It shows the placement of transcutaneous electrical nerve stimulation, or a TENS unit. It shows the electrodes on the back for relief of labor pain. This is figure 14-6 in your textbook, water therapy during labor. A shows the use of shower during labor. B is a woman experiencing back labor, relaxes as her partner sprays warm water on her back. C is the laboring woman relaxing in a jacuzzi. Note that the fetal monitors can continue through time in the jacuzzi, and you want to make sure you have waterproof electronic monitors before you stick the mama in the tub with the fetal ultrasound and toco parts. This is figure 14-7, which is the intradermal injections of 0.1 ml of sterile water in the treatment of women with back pain during labor. If you read the information on the picture, it lets you know that sterile water is injected into 4 locations on the lower back. The injection should raise a bleb on the skin. You guys know what the bleb is after you've learned how to do your TB injections. Simultaneous injections administered by 2 clinicians will decrease the pain of the injections. Now, what is an intradermal water block? I just wanted to talk about this real briefly. I've never really seen it done, but a lot of students are quite interested in this phenomenon. But what an intradermal water block, it involves the injection of small amounts of sterile water by using a fine gauge needle into 4 locations on the lower back to relieve low back pain. It is a simple procedure to perform, and there is evidence that it is effective, perhaps because of the gate control mechanisms. You stimulate pain in other areas, and with the gate control, your body can only handle stimulus of pain from maybe one area at a time. So if you have your abdomen hurting from the contraction, they elicit pain in the back, and that pain distracts from the effect of the contraction. Okay, moving on. Pharmacologic pain management. Pharmacologic measures for pain management should be implemented before pain becomes so severe that catecholamines increase and labor is prolonged. It is unacceptable for women in labor to endure several severe pain when safe and effective relief measures are available. Pharmacologic and non-pharmacologic measures, when used together, increase the level of pain relief and create a more positive labor experience for the woman and her family. Non-pharmacologic measures can be used for relaxation and pain relief, especially in early labor. Pharmacologic measures can be implemented as labor becomes more active and discomfort and pain intensify. Pharmacologic pain management continued. Sedatives. Sedatives relieve anxiety and induce sleep. They may be given to a woman experiencing a prolonged latent phase of labor when there is a need to decrease anxiety or promote sleep. They may also be given to augment analgesics and reduce nausea when an opioid is used. The 2 main sedatives that you may see in labor and delivery or the OB setting is your Seconal and Phenergan. However, we don't use Phenergan as much as we used to, and Seconal The last I heard was off the market. I haven't seen Seconal in at least 10 plus years. Anesthesia and analgesia. Nursing management of obstetric analgesia and anesthesia combines the nurse's expertise in maternity care with a knowledge and understanding of anatomy and physiology and of medications and their therapeutic effects, adverse reactions, and methods of administration. The type of analgesic or anesthetic chosen is determined in part by the stage of labor of the woman and by the method of birth plan. I really want you guys to review box 14-4 in your textbook. You may see that again. Systemic analgesia. Opioids provide sedation and euphoria, but their analgesic effect in labor is limited. The pain relief they provide is incomplete, temporary, and more effective in the early part of active labor. All opioids, however, cause side effects, the most serious of which is respiratory depression. Other undesirable opioid side effects include sedation, nausea and vomiting, dizziness, altered mental status, euphoria, decreased gastric motility, delayed gastric emptying, and urinary retention. Opioids also readily cross the placenta. Effects on the fetus and newborn can be profound, including absent or minimal fetal heart rate variability during labor and significant neonatal respiratory depression requiring treatment after birth. Opioid agonist analgesics. Opioid agonist analgesics commonly used in obstetrics are your meperidine or your Demerol and fentanyl or Sublimase. As pure opioid agonists, they stimulate major opioid receptors. They have no amnesic effect but create a feeling of well-being or euphoria and enhance a woman's ability to rest between contractions. Your opioid agonist antagonist analgesics. An agonist is an agent that activates or stimulates a receptor to act. An antagonist is an agent that blocks a receptor or a medication designed to activate a receptor. The two that we use in OB is your Stadol, which is my favorite, and Nubane. They are commonly used opioid agonist and antagonist analgesics. Their major advantage is their ceiling effect for respiratory depression. Higher doses do not produce additional respiratory depression. They are less likely to cause nausea and vomiting, but sedation may be as great or greater when compared with pure opioid agonists. As a result of these effects, parenteral opioid agonist antagonist analgesics are used more commonly during labor than the opioid agonist analgesics. Intramuscular, subcutaneous, and intravenous routes of administration can be used, but the IV route is preferred. This classification of opioid analgesics, especially your Nubane, is not suitable for women with an opioid dependence because the antagonist activity could precipitate withdrawal symptoms in both the mother and her newborn. Opioid antagonists. Opioids such as meperidine and fentanyl can cause excessive CNS depression in the mother, the newborn, or both. Although the current practice of giving lower doses of opioids intravenously has reduced the incidence and severity of opioid-induced CNS depression, opioid antagonists such as naloxone or Narcan can promptly reverse the CNS depressant effects, especially respiratory depression in most situations. Nerve block analgesia and anesthesia. A variety of local anesthetic agents are used in obstetrics to produce regional analgesia. and regional anesthesia. Local perineal infiltration anesthesia may be used when an episiotomy is to be performed or when lacerations must be sutured after birth in a woman who does not have regional anesthesia. Rapid anesthesia is produced by injecting approximately 5 to 15 mLs of lidocaine into the skin and then subcutaneously into the region to be anesthetized. Your pudendal nerve block is administered late in the second stage of labor, is useful if an episiotomy is to be performed or if forceps or vacuum extractor is to be used to facilitate birth. It can also be administered in the third stage of labor if an episiotomy or laceration must be repaired. Spinal anesthesia. An anesthetic solution containing a local anesthetic alone or in combination with an opioid agonist analgesic is injected through the third, fourth, or fifth lumbar interspace into the subarachnoid space where the anesthetic solution mixes with the cerebrospinal fluid. Disadvantages. There are some major disadvantages with use of spinal anesthesia. The most important to note is marked hypotension, impaired placental perfusion, and an ineffective breathing pattern may occur during spinal anesthesia. So to prevent this, before induction of the spinal anesthetic, the maternal vital signs are assessed and a 20 to 30 minute electronic fetal monitor strip is obtained and evaluated. In addition, the woman's fluid balance is assessed. A bolus of IV fluid, usually 500 to 1,000 mLs of LR, may be administered 15 to 30 minutes before induction of the anesthetic to decrease the potential for hypotension caused by sympathetic blockade. Although the practice guidelines for obstetric anesthesia, published by the American Society of Anesthesiology, states that this pre-anesthetic fluid bolus is not required, it is still usually administered in most clinical settings. The fluid that is used for the bolus should not contain dextrose, which could contribute to neonatal hypoglycemia. After induction of the anesthetic, maternal blood pressure, pulse, and respirations, and fetal heart rate and pattern must be checked and documented every 5 to 10 minutes. If signs of serious maternal hypotension or fetal distress develop, emergency care must be given. Make sure you guys look at the emergency box on page 371 in your textbook. It goes over what we do to treat severe hypotension after spinal or epidural is placed. Headache. Leakage of CSF from the site of puncture of the dura mater is thought to be the major causative factor in post-dural puncture headache, commonly known as the spinal headache. Spinal headache is much more likely to occur when the dura is accidentally punctured during the process of administering an epidural block. Treatment includes oral analgesics and methylxanthines. If the headache persists, an autologous epidural blood patch is the most rapid, reliable, and beneficial relief pressure for a spinal headache. The procedure for this, we usually draw about 20 mLs of blood directly from the mom. We then take that blood and inject it into the lumbar epidural space, which creates a clot that patches the tear or the hole in the dura mater. Treatment with the blood patch is considered if the headache is severe or debilitating or does not resolve after conservative management. This is figure 14-8 in your textbook, Pain Pathways and Sites of Pharmacologic Nerve Blocks. If you look at picture A, it shows the pudendal nerve block, which is suitable during second and third stages of labor and for repair of episiotomy or lacerations. Figure B shows an epidural block, which is suitable for all stages of labor and types of birth and for repair of episiotomies and lacerations. This is figure 14-9. This is showing the procedure of a pudendal nerve block. The use of a needle guide, which you see the trumpet, which is right here, and the luer lock syringe to inject medication. This is figure 14-10. A shows the membranes and spaces of spinal cord and levels of sacral, lumbar, and thoracic nerves. B, the cross section of the vertebra and spinal cord. And C, the level of anesthesia necessary for cesarean birth and for vaginal birth. And if you see cesarean birth, they should be numb from their nipple all the way down to their feet. And then for the vaginal birth, from this area all the way down to their feet. This is figure 14-11, which shows positioning for spinal and epidural blocks. A is the lateral position. B is the upright position, and usually B, the upright position, is used the most. And C, the catheter for the epidural is taped to the woman's back with the port segment located near her shoulder. So here's where the epidural was placed. They have the wire or the tube, they tape it up to the back, and then it connects to the epidural pump. This is figure 14-2, which shows the blood patch therapy for spinal headache. So like I said, they would draw approximately 20 mLs of blood from the mom, and they stick it back into the space where they think they punctured the dura. Okay, nerve block, analgesia, and anesthesia. Epidural anesthesia and analgesia is the most effective pharmacologic pain relief method for labor that is available. As a result, it is used by most women in the United States. The woman must cooperate and maintain her position without moving during the insertion of the epidural catheter to prevent misplacement, neurologic injury, or hematoma formation. After the epidural has been initiated, the woman is positioned preferably on her side. This is done so that the uterus does not compress the ascending vena cava and descending aorta, which can impair venous return, reduce cardiac output and blood pressure, and decrease placental perfusion. Her position should be alternated from side to side every hour. Upright positions and ambulation may be possible depending on the degree of motor impairment. Oxygen should be available if hypotension occurs despite maintenance of hydration with IV fluid and displacement of the uterus to the side. A medication known as ephedrine, which is a vasopressor used to increase maternal blood pressure when her blood pressure drops too low after epidural placement, and increased IV fluid infusion may be needed if the blood pressure drops. Again, I want you guys to see the emergency box that's in your textbook. The fetal heart rate and pattern, contraction pattern, and progress in labor must be monitored carefully because the woman may not be aware of changes in the strength of the uterine contractions or the descent of the presenting part. Disadvantages of epidurals. I want you to see box 14-6, which is titled Side Effects of Epidural and Spinal Anesthesia. Epidural and intrathecal spinal opioids. Opioids also can be used alone, eliminating the effect of a local anesthetic altogether. The use of epidural or intrathecal opioids without the addition of a local anesthetic agent during labor has several advantages. Opioids administered in this manner do not cause maternal hypotension or affect vital signs. The woman will feel contractions but not pain. Her ability to bear down during the second stage of labor is preserved because the pushing reflex is not lost and her motor power remains intact. Contraindications to epidural blocks. These contraindications include hemorrhage, hypotension, coagulopathy, such as conditions we see in pregnancy, such as DIC and HELP syndrome, infection at injection site, allergy to the anesthetic drug, maternal refusal or inability to cooperate, and maternal cardiac conditions, certain maternal cardiac conditions. Epidural effects on the newborn. Analgesia or anesthesia during labor and birth has little or no lasting effect on the physiologic status of the newborn. There is no evidence that the administration of maternal analgesic or anesthetic agents during labor and birth has a significant effect on the child's later mental and neurological development. Nitrous oxide. Nitrous oxide mixed with oxygen can be inhaled in a low concentration to provide analgesia during the first and second stages of labor. At the lower doses used for analgesia, it helps women relax, gives them a sense of control, and reduces their perception of pain, even though they may still be aware that pain is pregnant. You see nitrous oxide used extensively in other countries. It used to be used here, then it kind of faded away. Now it's getting popular in the United States as an alternative therapy. And one of the things with it is that it can be self-administered. You just hold the mask to your face, your mouth, and cover your nose and breathe in. Okay, general anesthesia. General anesthesia rarely is used for uncomplicated vaginal births. It is used for only about 10% of cesarean births in the United States. General anesthesia may be necessary if a spinal or epidural block is contraindicated or if indications necessitate rapid birth without sufficient time or available personnel to perform a block. The major risks associated with general anesthesia are difficulty with or inability to intubate and aspiration of gastric contents. If general anesthesia is being considered, give the woman nothing by mouth and ensure that an IV infusion is in place. If time allows, pre-medicate the woman with a non-particulate clear oral antacid such as Bicitra, and you'll see that in the hospital we give Bicitra to our women who are getting C-sections, even if they're using the spinal or the epidural. The Bicitra neutralizes the acidic contents of the stomach. Aspiration of highly acidic gastric contents will damage lung tissue. Some anesthesia care providers also order the administration of a histamine H2 receptor blocker such as Pepcid or Zantac to decrease the production of gastric acid and Reglan to accelerate gastric emptying. This is figure 14-13. Is showing the technique of applying pressure on the cricoid cartilage to occlude the esophagus to prevent aspiration of gastric contents through an induction of general anesthesia. You may also be asked to do cricoid pressure when the CRNA or the anesthesiologist is attempting to intubate the patient for surgery. Okay, care management. The choice of pain relief interventions depends on a combination of factors, including the woman's special needs and wishes, the availability of the desired method or methods, the knowledge and expertise in non-pharmacologic and pharmacologic methods of health care providers involved in the woman's care, and the phase and stage of labor that particular woman is in. So, your non pharmacologic interventions. The nurse supports and assists the woman as she uses non pharmacologic interventions for pain relief and relaxation. During labor, the nurse should ask the woman how she feels to evaluate the effectiveness of the specific pain management techniques used. Appropriate interventions can then be planned or continued for effective care, such as trying other non pharmacologic methods or combining non pharmacologic methods with medications. Informed consent. Pregnant women have the right to be active participants in determining the best pain care approach to use during labor and birth. The primary health care provider and anesthesia care provider are responsible for fully informing women of the alternative methods and alternative methods of pharmacologic pain relief available in the hospital. A description of the various anesthetic techniques and what they entail is essential to informed consent. Even if the woman received information about analgesia and anesthesia earlier in her pregnancy, we should go over it with them at the time of delivery. Timing of administration. It is no longer recommended that women in labor reach a certain level of cervical dilation or fetal station before receiving epidural anesthesia. In the past, we told women that most physicians wanted the woman to be at least 4 centimeters or in active labor before they were given their epidural. It is, however, still recommended that the administration of systemic opioid analgesics be delayed until labor is well established. Plan of care and implementation continued. The administration of medication, as I said before, the IV is the preferred route. Safety and general care. When you're talking about anesthesia in obese women, they're usually harder to intubate if we have to do a general anesthesia, and it's often harder to find the prominent spaces when they're trying to do epidural or spinal. The nurse, for safety and general care, the nurse monitors and records the woman's response to non-pharmacologic pain relief methods and to medications. This includes the degree of pain relief, the level of apprehension, the return of sensations and perception of pain, and allergy or adverse reactions. The nurse continues to monitor maternal vital signs and fetal heart rate and pattern at frequent intervals. The strength and frequency of uterine contractions, changes in the cervix and station of the presenting part, the presence and quality of the bearing down reflex, bladder filling, and state of hydration. Determining the fetal response after administration of analgesia or anesthesia is vital to the OB nurse's role. As the OB nurse, we have a lot of autonomy in labor and delivery because usually it's just us and the patient, and sometimes the doctors can be on the unit or they may be in the office seeing their other patients. So it's the labor and delivery's nurse's role to recognize when a normal labor starts going abnormal and high risk situations start to come up. So we're always looking to make sure that no adverse events occur and that the safety of our mother and our fetus is our highest goal or priority. All right, question. The most important nursing intervention After injection of epidural anesthesia is monitoring A, urinary output, B, contractions, C, maternal blood pressure, or D, intravenous infusion rate. Hopefully everyone answered C, which is maternal blood pressure. Epidural anesthesia may produce maternal hypotension due to vasodilation. The mother is prone to bladder distension and this needs to be monitored. However, this does not become a problem until 1 to 3 hours later. Continuing monitoring of the contraction is important because they may be altered by the epidural. However, this is not the most important nursing intervention after the epidural is administered. The intravenous infusion needs to be maintained before, during, and after the epidural. However, it is not the most important nursing intervention at this point. This concludes the audio lecture for Chapter 14, Pain Management. Thank you.